Hello, this is Robin. Here's I'm going to be doing a presentation on my cardiovascular soap note. My patient is RK. He's a 65-year-old Caucasian male who arrives to the clinic alone, and he is his own reliable self-historian. His chief complaint is he said about 6 weeks ago he started having racing heart that happened for a couple minutes, and then it's been kind of happening more and more to the point now where it's pretty constant. So the heart racing started about 6 weeks ago. He says his heart starts thumping and lasted 2 to 3 minutes the first time around, and now it's happening pretty much all the time. He says, I feel like I'm running a race, but I'm not. And he has no chest pain. Pain is 0 out of 10. Past medical history: he has a 10-year history of hypertension, diagnosed in 2015. No hospitalizations. He did have an appendectomy in 1971. Allergies: he's got no known environmental, food, or drug allergies. Medications: he takes hydrochlorothiazide and losartan. Hydrochlorothiazide 25 milligrams and losartan 100 milligrams. He takes that twice daily, and then he's also on amiodarone 200 milligrams once a day. No pertinent family history. Social history: he lives alone. His occupation is a retired truck driver, just this year. Does not smoke, never has. He does drink 1 to 2 alcoholic beverages a week on average, and he denies any illicit drug use, including marijuana. Review of systems: constitutionally, he denies any weight loss or gain of more than 10 pounds in a month. He denies fevers and fatigue. Cardiovascular: he denies any orthopnea, shortness of breath at rest, or angina. He denies vertigo or syncope, and he reports heart palpitations. Respiratory: he denies any shortness of breath, cough, production of sputum, wheezes, or shortness of breath at rest. GI: he denies any nausea, vomiting, diarrhea, or constipation, reports normal appetite. Neuro: denies irritability, trouble sleeping, or nervousness. Vitals: his heart rate is 110. His blood pressure is 130/68. His temperature is 98.4. O2 sat is 99% on room air. Respiratory rate is 17, and his pain is 0 out of 10. His height is 5'10", and he weighs 207 pounds. That puts him at 29.7 BMI. And we did an EKG, and it showed atrial fibrillation at a rate of 112. On physical exam, his neck is supple, no adenopathy, the thyroid is smooth without any goiter. Cardiovascular: no heaves, thrills, or lifts. There is some tachycardia that's irregular, S1, S2, without a gallop, murmur, or click. He does have brisk capillary refill less than 2 seconds, and no cyanosis. Respiratory: his chest is symmetrical on inspiration and expiration. There's no use of accessory muscles. AP ratio is 2 to 1. Bronchoscopy: lung sounds throughout all lung fields, both anterior and posterior, without any rales, bronchi, wheezes, or crackles heard, and no nail clubbing or cyanosis. So differential diagnosis number 1 is thyrotoxicosis. He does report palpitations, but he has a normal appetite. He's had difficulty swallowing or voice changes. He has no irritability, nervousness, or trouble sleeping. He denies weight loss, sweating, and intolerance to heat. So not likely, but something to look at that's pretty easy. Second diagnosis would be electrolyte imbalance. He reports palpitations, denies any cramping, dehydration, or poor appetite. He does report to me that he drinks about 64 to 70 ounces of water daily. Persistent atrial fibrillation is the third differential diagnosis. and we have a positive EKG for AFib. He also reports pretty consistent heart palpitations and racing heart. He denies any angina, vertigo, or syncope, and shortness of breath at rest. So the main diagnosis is persistent atrial fibrillation, which is J48.21 on the ICD-10 code. So for diagnostics, we're going to get a CBC, a CMP to rule out. We want to look for the CBC just to rule out any type of anemia, because that can be a cause of some tachycardia and AFib. And then since we're already getting blood, and then a CMP to look at the electrolytes. We also want to get a TSH and a T3 and a T4. And then anemia can also be a cause of AFib, and so we're going to get a iron, ferritin, transferritin, and a TIBC. We're going to refer him to cardiology for further evaluation and testing. We're going to educate him on stroke symptoms and what to do about that using the acronym BFAST. We're going to educate him. We're going to give him some Eliquis. So we're going to educate him about the Eliquis and what to look for as far as bleeding, bleeding gums, bloody nose, lactary stools would be something that he would need to notify us about. We're also going to advise him to go to the drugs website to get a copay card for $10 a month. Eliquis can be quite expensive even with insurance coverage. And then we're going to advise him to keep taking all of his other blood pressure medications along with carvedilol to lower his heart rate and kind of hopefully convert him from AFib to a regular rate. And then also advise him that since he does go to the gym, that he should take the carvedilol after he goes to the gym and be on the lookout for exercise-induced intolerance. When patients exercise on carvedilol, the rate doesn't go up, and so they can get dizzy and they can actually pass out. So we'll need to educate him to, if he does feel that while he's working out, to just take it a little bit easier. And then, sorry, we're going to follow up. I can't see my screen. We're going to follow up with him. So we're going to treat him with Eliquis 5 milligrams twice daily for stroke prophylaxis. And then carvedilol, we're going to start him with a 3.125 milligram twice daily for heart rate control. And then we're going to follow up with him in 2 weeks and ask him to return to the clinic for any concerns. And if he has any symptoms of chest pain or he has stroke-like symptoms, that he should call 911. And that is the end of my case. Thank you.